Welcome, folks. We're going to give everybody a couple more minutes to trickle in. Thank you for being here. Welcome to all of those who just came on. We're going to give everybody a couple more minutes.
Yeah, that's cool, Yuli. Maybe let's give it like 2 or 3 more minutes.
Yeah.
Thanks.
Welcome, everybody. Going to give folks a couple more minutes to jump on. Okay, we will get started in about 1 minute. Thank you all for being here. Right, to be mindful of everybody's time, we'll get started. And there will be a recording at the end for those that registered. Welcome, welcome. Thank you so much for joining us today. My name is Yuli Smith, and I'm a licensed midwife in California. Myself and the organization I represent, Global Communities Healthy Start, which serves San Diego County and Riverside County in Southern California. We are a part of Midwifery Access California, and I'm thrilled to be able to introduce this webinar as a part of our advocacy work with the coalition working to improve access to midwife-led care in Medi-Cal and beyond. Thank you. Next slide, please. This webinar is part of a series that you can find on midwiferyaccesscalifornia.org. This particular webinar was created in partnership with the Western Center on Law and Poverty, as well as Global Communities. Western Center on Law and Poverty was formed in 1967 by a passionate group of attorneys and legal scholars from USC, UCLA, and Loyola law schools who sought to create a unique organization driven by the belief that low-income Californians deserve the finest possible legal representation before every institution that shapes their lives. For over 50 years, the Western Center has advocated on behalf of Californians experiencing poverty in every branch of government, from the courts to the legislature. Through the lens of economic and racial justice, they litigate, educate, and advocate around health, housing, public benefits, and policies and administration. And Global Communities, the organization I'm representing today, we have a Healthy Start program, and we serve San Bernardino, San Diego, and Riverside counties. We provide free prenatal, childbirth education, postpartum, and breastfeeding support with a focus on Black, Native Hawaiian, Pacific Islander, and Native American, Native Alaskan parents throughout these counties. Enrolled participants may access free midwifery and doula services, as well as other resources to ensure that they have a positive birth outcome. Services are available in English, Spanish, Somali, Haitian Creole, and French. Next slide, please. This webinar series was generously funded by the California Nurse Midwife Foundation. You can scan the QR code on this slide to learn more about their work and their various funded projects. The foundation's mission is to enhance maternal health in California and address disparities in birth outcomes by advocating for universal access to the midwifery model of care, driven by a diverse midwifery workforce. CNMF was funded by has funded various initiatives that fall into 3 categories that you can see on this slide. They have their MAMA funding and initiative, their Bloom initiative, and their Seed initiative. Okay. Specifically, I'd love to highlight the Seed initiative that directly funds midwifery student scholarships, particularly for those that are BIPOC and LGBTQ plus students. as part of their commitment to diversify the midwifery workforce. Okay. Hopefully, many of you are already familiar with Midwifery Access California, but for those of you who are new to this webinar series and the coalition's work, Midwifery Access California, or MACA, is a multi-stakeholder coalition started in 2021. As of 2024, the coalition has over 60 partners, including 25 midwifery practices. This coalition also includes state and local agencies and various community-based organizations listed here that desire to improve outcomes, uh, increase care, and reduce racism-based disparities in maternal health. Thank you. Uh, the coalition, it spans across many diverse stakeholders. But we all agree that access to midwifery care is a crucial strategy for improving reproductive health care access and outcomes in California. We aim to expand the midwifery model of care here in California, including community midwives or licensed midwives, so that the needs of those who need the care the most, people of color, marginalized populations, and geographically isolated or rural folks have accessible, high quality maternity and reproductive health care. Thank you again for being here. And with that, I'll pass it over to Holly Smith. Oh, Holly, you're muted.
Is muted. Thanks so much. Appreciate you doing our introduction, and thank you everyone for being here today. I have the great pleasure to introduce our speaker for today's webinar, Atisha Burrell. I'll just give a quick bio of Atisha's extensive background. Atisha is a fourth-generation San Francisco native of Bayview Hunters Point. She has dedicated her career to empowering the underserved to be agents of change in their communities and healers for themselves and their lineage. As a reproductive justice advocate, researcher, and health educator, Atisha has been facilitating trainings and workshops since 2011 on a variety of related topics. She has a Bachelor of Arts in Sociology from St. Mary's College of California. Atisha has over a decade of experience developing and managing community-based organizations, public health entities, and academic institutions. In 2016, Atisha received her full spectrum doula certification from a community-based organization in Oakland, California called Roots of Labor Birth Collective. As a full spectrum doula, she is trained to support folks who are currently pregnant, birthing, and folks who recently gave birth. She has also been certified as a queer preconception and reproductive health counselor since 2016 and provides fertility doula support to people who are navigating their conception journey. In 2018, Atisha became the population health manager at San Francisco Health Plan, monitoring the provision of cultural and linguistic services and helping to develop quality improvement initiatives that positively impact San Francisco's Medi-Cal population. Atisha also sits on committees and boards both at San Francisco Department of Health and Alameda County Public Health Department, addressing reproductive justice, cancer disparities, and timely access to perinatal care. Importantly, Atisha is also an organizing member of the Doula Medicaid Project facilitated by the National Health Law Program for state legislation creating Medi-Cal coverage of doula care. This program was hugely impactful in finally implementing reimbursement in Medi-Cal for doulas in California. Most recently, in April 2022, Atisha completed training with the Breastfeeding Cultural Outreach Task Force and became a certified peer lactation support counselor. And in her current role, she is a senior health advocate at Western Center on Law and Poverty, another organization which is partnering with us to create this webinar and others, and is part of Midwifery Access California. So with that, I'm going to hand it over to Atisha.
Thank you, Holly. And thank y'all for being here today for this webinar. It's important for me to be able to share with community organizers and advocates about what midwifery is and why access is so important. We hear a lot of talk about doulas, we hear a lot of talk about reproductive justice, but we still get a lot of questions about what is a midwife. And so hopefully today's webinar is going to demystify that for you and help you be better advocates in your communities that you serve. So our agenda today is going over the types of midwives in California and what midwives do, what research says about the improved health outcomes of people who are receiving midwifery care. We're going to talk about the essential role of doulas and what the research says about the better health outcomes for folks who have doulas attending their births. And then we're going to also learn more about how doulas and midwives work together as an integrated part of someone's care team, and how midwife and doula benefits are covered by Medi-Cal, and how you can help your community members have better access to those benefits. So it's important for me, I think, to start this conversation off with context. So often when we talk about birth and reproductive justice, we start with where we are today, without always thinking about how people have been giving birth since the very beginning of time. And what did that birth look like? Birth that was unmedicated, birth that had no Western or modern medical interventions, birth that was more holistic and a community-based model that really provided a safe space for all people giving birth, and a safe space for the baby as well. We saw a shift in that in our modern day time during the antebellum period, where enslaved women in the United States really were forced to give up their reproductive freedoms. And we saw an encroachment on enslaved people and indigenous people's reproductive health and their sexual health. The United States system of chattel slavery really relied on what plantation owners called slave breeding to increase production and to cut cost. And so when we think about reproductive justice and its origins in this country, it's important to understand why some of those systemic issues that we're seeing today in terms of women not being listened to, we see laws being passed that really take away women's agency over their own bodies. The origins of that kind of thinking around women not having the right to choose what happens to them and their bodies really starts with our history in this country with slavery. Thomas Jefferson bragged to George Washington that the birth of Black children was increasing Virginia's capital stock by 4% annually. And so women were often raped and forced to have children by their enslavers. These enslaved women were also forced to breastfeed their master's children, denying their own children sustenance. And even after slavery ended, we saw this continued practice of wet nurses and nannies. And even today, we see how the nanny culture in the United States, how that impacts that person's family and their time to be able to spend with their own children. And so this is where we can see some obvious links between slavery and modern day American life in our birthing system that we have in this country. We can move through the photos. Next slide. And so this is just a short timeline of the history of birth in the US. With pre-industrialization, as I mentioned, we had traditional healers, medicine makers, midwives who worked with nature and the land and really paid attention to how women's bodies naturally gave birth and really honored that birthing process. And then when we saw the industrial era, we saw how really colonization impacted birth with slavery and capitalism. and you know how land was also taken from indigenous people and how that impacted a person's birth as well. And then we moved to in the United States with the medical industrial complex. We saw a decrease in granny midwives or Black midwives. We saw an increase in indigenous genocide and the rise of more standardized, what we call modern medicine, with the leadership of Dr. James Marion Sims. Um, we went through a wave of feminism, second wave feminism, and we saw a resurgence in midwifery around the 70s. And the term doula was coined by Dana Raphael. And doula is a Greek word that means woman servant. And this resurgence really was sought to reclaim women's agencies over our bodies and our birthing experience. Um, and then we started to move into a reproductive justice framework and how we are talking about birth in the US. Loretta Ross and Sister Song really are some of the pioneers for talking about reproductive justice and organizing around reproductive health. And today we see a new wave of Black and people of color birth work and organizing with Standing Rock and Femme Goddess and other organizations that have been working to eliminate health disparities that are disproportionately affecting Black folks and Indigenous folks in our country. Next slide. I think some is missing. It's okay. So there it is. Um, so for the granny midwives, as I mentioned, up until the mid 20th century, when obstetricians and hospitals became the primary location for delivery, these granny midwives provided most of the care for poor and rural pregnant women, both Black and white throughout the South. Granny midwives were healers. They were trained in their communities, um, and they were really birthed out of a legacy of slavery, but also they were central to healthcare during segregation as well. Many enslavers employed granny midwives because it was more frugal or cost saving than using local physicians who charged for their medical services. Some plantation owners even went so far as to hire out midwives to other local plantation owners as a means of acquiring more income. And so these were very skilled professionals who were valued in their communities. And nursing and granny midwifery were two roles in particular that granted enslaved women greater authority in comparison to other possible positions or jobs that were worked in the field specifically. Um, Dr. James Marion Sims is someone that I mentioned before. He was a 19th century physician who developed tools and surgical techniques related to reproductive health. He's credited as the father of modern gynecology. He got his start as the primary doctor in Montgomery, Alabama, and he was known for experimenting on enslaved Black women, performing surgeries without any anesthesia. And he is coined with really inventing like reproductive health. And most of his research he wrote about in his autobiography. And a quote that he said is, "There was never a time that I could not at any day have a subject for operation." And that's because he enslaved the women that he experimented on. And we're just going to play a short video about granny midwives.
Got to the land and the women turned around. I'm crying, look way across that ocean, Lordy, at my husband found God moved down the water. What a line down was sleep for he was hard. Oh, well, he woke up in a great fright as a many gunshot for God moved down the Jacob Nash was a millionaire, Lord, a plenty money to spare. When the great Titanic was sinking down, well, he could not pay his fare. God moved down the water. Constitute and refuse to shine, Lord. Clouds in heaven, stars in the sky. The rock the foot, my shepherd is being God. Taking my G find and let him away, Lord. Help on the money, call a Calvary. The ripple is deep, find the raffle is hand, find the trouble God, people in Jerusalem. God move, down the wide, hallelujah. God move. Seawall to keep the waters down. I want the high top of that ocean, Lord, put the water all over the town. God move on the water, God move. Taking my Jesus down from the cross, they wrapped him up in a fine linen cloth. A nature suspended as 3 o'clock at the foot of that cross was a javelin bound. God move on the water. Constitute and refuse to shine, Lord. Clouds in heaven, stars in the sky. The rock the foot, my shepherd is being God. Taking my G find and let him away, Lord. Help on the money, call a Calvary. The ripple is deep, find the raffle is hand, find the trouble God, people in Jerusalem. God move down the wide, hallelujah. God move. Seawall to keep the waters down. I want the high top of that ocean, Lord, put the water all over the town. God move down the water. God taking my Jesus down from the cross. They wrapped him up in a fine linen cloth. A nature suspended as 3 o'clock at the foot of that cross was a javelin block. God knew.
Thank you. Hopefully y'all learned about midwives in this country and its origins. It's really important that we pay homage to uh, where our modern midwifery movement, where it stems from. We also saw a depiction of midwives as witches during not just America's history of slavery, but also in Europe as well. And midwives were seen as people who were dangerous. And so there started to be a smear campaign in the 1920s and 30s that depicted these midwives even not just Black midwives, but midwives in general as dangerous people that can't be trusted. And really, this invention of witch really goes in to perpetuating patriarchy and capitalism. And so we saw with the witch hunts also a hunt on midwives. Next slide. So where are we today? We see that in 2022, about 1 in 3 live births in the US were delivered by cesarean section. This is well above the 10 to 15% rate that the World Health Organizations consider ideal. We see an increase in unnecessary medical interventions in the United States with the increase in hospital births. Next slide. The 2021 to 2023 average percentage of pregnant people who receive no prenatal care in the US is highest amongst Indigenous American women at 12.6% and Black women at 9.8% compared to white women at 4.7%. We also see that Hispanic or Latine women who receive no prenatal care, the rate was 9.1%. And then for Asian and Pacific Islander women, it's 5.3%. More than 5.6 million women in the US live in counties with limited or no access to maternity care services. And so that is not just people who live in rural areas. Sometimes we think that rural areas or people who live in the country are the only folks that are isolated from maternal care. But we also see this in urban areas, areas where there is a high rate of Black folks, oftentimes living in urban centers where there is not as much access to care or timely access to care. Next slide. Next slide. So you may be asking yourself, what's the difference between doulas and midwives? We found that these are some of the best solutions that we have to combating some of the health disparities that we just talked about, and both are necessary. So doulas provide emotional, physical, and informational support throughout pregnancy. This support becomes continuous during labor, birth, and the immediate postpartum period. Doulas often come from the communities that midwives serve and making them a key advocate and connector to the social needs and services that the people that they are supporting have. And midwives, they're licensed healthcare providers. And they provide pregnancy, labor, birth, and postpartum care. And they work to keep pregnant people and babies healthy, safe, and low risk. Midwives also provide emergency care when necessary. And so they are both professionals working together to ensure that the pregnant person is fully supported throughout their pregnancy, labor, birth, and postpartum. And this is something that California recognizes as something that's important, way to combat the maternal health crisis. And so as of January 1st, 2023, managed care plans are required to cover doula services for prenatal, perinatal, and postpartum Medi-Cal members. Next slide, please. And so the California Department of Healthcare Services defines doulas as birth workers who provide health education, advocacy, and physical, emotional, and non-medical support for pregnant and postpartum people before, during, and after childbirth, including support during miscarriage, stillbirth, and abortion. And as far as the doula scope, of work as defined by the Department of Healthcare Services. Doula services are aimed at preventing perinatal complications and improving health outcomes for birthing parents and infants. Doulas are also able to offer various types of support, including health navigation, lactation support, development of a birth plan, and providing community-based resources to their clients. Doulas are not licensed medical providers and they do not require supervision. And so this is a chart that outlines the scope from the CMQ-CC toolkit to support vaginal birth and reduce primary cesarean. And so we see that doulas are really essential in helping families to advocate for themselves, make informed decisions, understand what possible medical intervention might look like, and really help for the family to feel supported if they did need to have a cesarean section, how to navigate care afterwards. So doulas are also essential in helping to reduce cesarean rates as we see outlined here. Next slide. So doula services can be provided virtually via telehealth or in person at any location really, and it's not limited to a person's home or hospital or doctor's office. And so the Medi-Cal benefit really makes it so that doula services are available to all people. So during their pregnancy, during labor and delivery, again, during any stillbirth or miscarriage, abortion, and also within 1 year of the end of the person's pregnancy. So if a person wanted to have a postpartum doula, they could. Doulas are not prohibited from providing any assistive or supportive services in the person's home. And they also are able to ensure that the person is able to get the support that they need without cost. And so doulas can, again, connect that client to additional resources that are available as a covered Medi-Cal benefit. And doulas are also able to teach classes to members, childbirthing classes or parenting classes to members as well. Next slide. So many folks who I talk to in community don't always realize that midwifery care is also a covered Medi-Cal benefit. So certified nurse midwives and licensed midwives are mandated by federal law. And so this law mandates coverage of services furnished by certified nurse midwives as legally authorized by the state. And California law requires coverage of both certified nurse midwives and licensed midwives. The California state plan authorizes certified nurse midwives and licensed midwives as providers of all services permitted within the scope of the practitioner's license. And so both of these midwives are authorized under state law to provide prenatal, intrapartum, and postpartum care, including family planning care and immediate care for the newborn. And there's some difference between the two provider types with regard to licensing, regulatory bodies, and circumstances under which they may be provided. And so at a minimum, managed care plans must ensure that staff assisting members through telephone inquiries inform members of their right to obtain services from an out-of-network freestanding birthing center, certified nurse midwife, and licensed midwife. And when they are not available in network, then they need to support that member in connecting with an out-of-network provider. Managed care plans must offer both licensed midwives and certified nurse midwife professional services. So one licensure type does not replace the other. And that's an important distinction for our members to understand. So the midwife scope, again, it looks a little bit different depending on the type of midwife. And so for certified nurse midwives, they are licensed as a nurse and certified as a nurse midwife by the California Board of Registered Nursing. Under state law, CNMs are permitted to attend cases of low-risk childbirth. They are able to provide gynecology care across the lifespan if consistent with their training, and they can provide abortion care in the first trimester. State law also details certain requirements for transfer of care when the patient's condition deviates from the legal definition of low risk. And about 3/4 or 76% of certified nurse midwives in the US undertake reproductive care in their full-time positions, and 49% have primary care responsibilities. Which is important to help members or your community members understand that they're able to get gynecology care from a midwife. For licensed midwives, they are licensed as a midwife by the Medical Board of California. They are permitted to attend cases of normal pregnancy and childbirth as defined by state law. And the state law also details a set of restrictions and requirements when a patient's condition deviates from the legal definition of normal. Next slide, please. And there is a detailed review of licensed midwives and certified nurse midwives and their scope of practice available in previous webinars in this series. You're able to scan this QR code if you would like to learn more, or you can go to midwiferyaccessca.org so you can watch the recordings. So again, under Medi-Cal, the freestanding birthing centers are required part of managed care plan benefits. And so managed care plans are required to provide their members with access to freestanding birthing centers. And so in accordance with federal and state network adequacy requirements, each managed care plan must include a minimum of one freestanding birth center in its provider network, to the extent that they're available in that managed care plan's contracted service area. And if the managed care plan is unable to provide access to freestanding birth centers in network, then they must reimburse out of network freestanding birth center services provided to its members. And this, again, is a really important distinction for your community members to be aware of, because oftentimes this information is not readily available on their Medi-Cal insurance provider's website, and it's not always advertised. And so again, I often get feedback from folks that they're not even aware that this was even a benefit. Next slide. So midwife-led models of care are associated with an increased likelihood of vaginal delivery, decreased likelihood of preterm birth, decreased likelihood of infant mortality, and it's estimated that increasing the percentage of pregnancies with midwife-led care to 20% from the current 8.9% over the next 10 years could lead to $4 billion in cost savings in this country. First-time birthing folks giving birth at medical centers where midwives were on their care team were 74% less likely to have their labor induced and 75% less likely to receive oxytocin augmentation. They were also 12% less likely to deliver by cesarean section than their counterparts at medical centers without midwives in attendance. So in low-risk pregnancies, midwifery care and labor is associated with decreased intervention, decreased cesarean, and operative vaginal births. And in multiparous women, an increased risk for shoulder dystocia. So we see that midwives really make a big difference in positively impacting the health outcomes for birthers and their babies. Next slide. So countries with better birth outcomes have a much higher proportion of midwives as their primary maternity provider. And again, you see here on the left table or chart, US has the highest mortality rate, and New Zealand has the lowest, and the US also has the lowest proportion of midwives as primary maternity providers. And so in countries where we do see a very low maternal mortality rate, those countries, midwives are the primary place of care for a pregnant person. Whereas in the United States, our primary place of receiving maternal care is at hospitals or with physicians. And so women, birthing people are often treated as if they are high risk, even though the majority of birthing people in this country are low risk. Next slide. Pregnant people who are supported by doulas are also more likely to have a vaginal birth. They're less likely to have a cesarean delivery, and they have babies who are less likely to have low 5-minute APGAR scores, which is an immediate post-birth measure of an infant's clinical status. And they're also less likely to experience adverse outcomes. Published data indicates that one of the most effective tools to improve labor and delivery outcomes is the continuous presence of support personnel, such as a doula. Given that there are no associated measurable harms, this resource is probably underutilized. And that is a quote from the American College of Obstetrics and Gynecology. Another important Medi-Cal spotlight is infant feeding. Managed care plans are required by the California Department of Healthcare Services to ensure that the obstetric, primary care, and pediatric providers in their network provide postnatal support to postpartum breastfeeding and infant feeding parents through continued health education, counseling, and the provision of medically necessary interventions such as lactation durable medical equipment. And plans must implement procedures to ensure that postpartum birthers and mothers receive necessary breastfeeding and infant feeding counseling and support immediately after delivery. Assessment of breastfeeding support needs is essential to the newborn's care after delivery. And for durable medical equipment, lactation management aids are covered by the Medi-Cal program, and managed care plans must provide this equipment, such as like breast pumps and breast pump kits, to lactating members. And that also includes electric breast pumps as necessary. Human milk banks are also a part of Medi-Cal benefits. And so this is a replacement for formula when a member has a medically diagnosed condition that precludes the use of regular food, and plans must arrange for the provision of human milk for newborns if a mother is unable to breastfeed or due to medical reasons and the infant can't tolerate or has contraindications for the use of formula. And at this time, the Mother's Milk Bank at Santa Clara Valley Medical Center in San Jose is the only human milk bank in the state of California. I think it's really important to highlight this as well because, again, this is something that even when I talk to providers, they're not always aware that this is covered. The DME as well as the milk bank is covered by Medi-Cal when medically necessary for folks who are trying to breastfeed. And this is also something that midwives can advocate for their patients. Next slide. So since midwives and doulas provide completely different services, communities can have both. Many people choose a midwife as their healthcare provider and a doula for extra support during labor, birth, or postpartum. In the hospital setting, doulas are particularly important in improving birth outcomes in our current system of care. And certified nurse midwives are they most commonly work in hospitals, but they can also work in health clinics, birth centers, in the home. And in the US, licensed midwives provide care for community births or births that are outside of the hospital setting, like in the home or at a freestanding birth center. And if someone is planning a home birth, they'll need to choose a midwife as their healthcare provider. as their training and expertise is crucial if problems arise. And a doula alone for a home birth is not the standard of care and not legally authorized. And so a person can have a doula attend their home birth with a midwife. And so a person can still have a doula support them, but they would be receiving their primary medical care or health care from their midwife. Parents also choose to have a doula for home birth because they are able to provide, again, that emotional support and that support after they give birth during the postpartum period, which is crucial. Next slide. And now we will open it up for if folks have any questions. Thank you.
Thanks so much, Atisha, for this really great presentation. I particularly loved hearing about the history. It just really puts into context where we are today. So for everyone who's wondering, you can enter a question into the chat or into the Q&A would probably be best. Either one is fine with us. I'm going to stop my share here so that I can also show you what is coming up in terms of our next webinar in this series. Give me 1 second and I will pull that up for everybody. All right, here we go. So if you go to the Midwifery Access ca.org, you will find this page here. And actually, maybe this is a good time to show people what is available on this website. This website will go through our work as a coalition. We've done some pretty significant work over the last few years in terms of best practices in contracting, reimbursement, and advancing midwifery care in Medi-Cal. And if you click that, you can actually get that document. We also have designed a California midwifery payment model, which really tries to pay for the value intense care that midwifery gives. This is similar to what our doula counterparts have done on the doula side with the Doula Medicaid project, making California, and correct me if I'm wrong, Atisha, but California is one of the highest paid, if not the highest reimbursed
Yes.
For doulas in Medicaid. That was due to the really hard work of advocates like Atisha and others to make sure that doulas have a living wage in this state, and so that the benefit doesn't go unused. So we have designed also for midwives a California midwifery payment model that takes into account all of the things that midwives do, especially in the community setting in terms of like the connections to social services, the significant teaching that happens with community midwives, the intensive labor support, and the doula Medicaid benefit has been really helpful in advancing community midwifery as well, because it means that doulas who are Medicaid providers can be paid through their reimbursement through Medicaid instead of the midwifery practice having to shoulder that burden. So this has really been good for both professions to advance maternity care. So we have a few things on this website of our work and what we do and how we're going about improving reimbursement, growing the workforce, advocating for updated laws, and more. If you go to the midwife-led care section, you'll see a lot of good stuff on why midwife-led care and some really good comparisons also to the dominant model of care, because sometimes folks aren't super connected to what makes the care model different. And we give a great some great embedded videos here of members of Midwifery Access California and their practices. Here, this is a great graphic showing how doulas and midwives and physicians work together for the best care and best outcomes for folks, as well as the model. And the model of care for as the healthcare provider for midwives also very much mirrors the same philosophies that doulas carry in supporting their clients. So this goes through the differences here, which is really helpful to folks who want to know the difference between dominant model and community model of care. Okay, finally, I'm now going to get to the webinar series, like I said. If you go here, you'll see our upcoming webinars. Here's today's. Our next one is on January 15th. We will be looking at, just going to click here, Black and Indigenous and Pacific Islander midwives in California and the importance of culturally concordant midwifery care to address racism-based disparities. This is going to be a really great event because it will be created in partnership with the California Coalition for Black Birth Justice and featuring Linda Janet Holmes, who's the author of Safe in a Midwife's Hands: Birthing Traditions from Africa to the American South. And she will be facilitating an expert discussion with Black, Indigenous, and Pacific Islander midwifery leaders in California, including Janelle Palacios, Joanna Galvez, Jaisha Wren, and Kiki Jordan, all midwives in California who have really interesting jobs that they are doing in creative and innovative care models as well. So please join us for that webinar. And remember, if you register and if you can't attend, you will still be able to access the recordings and all of the information that comes with it, like the slides and more. All right, I'm going to go back here. So let's see if there are any questions, feel free to put them in the Q&A. I'll give folks a couple minutes to do that. Also, I encourage you to fill out the survey that you will be getting as a follow-up to this webinar for what you would like to see in future webinars in this series. We have carved out a few ideas that you can see on our website, including midwives as abortion providers, training pathways to midwifery is another one. There's lots more coming, but we want to hear from the community in terms of what you want. So please answer that survey when you get a chance. You'll also be getting a little toolkit of information specific to this webinar. So doula services and Medicaid, as well as midwife services or Medi-Cal and midwife services and Medi-Cal, and just a little bit of go-to information that you can utilize in your communities for just knowledge base around Medi-Cal and both of these services, doula services and midwifery services. I also want to say thank you to Atisha for this wonderful webinar, and also to Yuli from Global Communities for being our facilitator. And I will just give it a couple more minutes and let's see if anybody pops into the chat. I do have one question as it relates to Medicaid, Atisha.
Yes.
This is kind of off the cuff. I know you didn't prepare for this question, or maybe you did. You probably prepared for many questions, but oh, Amina, thank you, says thank you so much. One question many people have is, why is it that the doula benefit in terms of what is reimbursed is higher than what other providers right now get, healthcare providers right now get in Medi-Cal, for instance, midwives and physicians in their reimbursement for Medi-Cal services?
Well, I mean, I think you kind of touched on it. I think it is really due to the organizing efforts of community doulas who demanded that they be reimbursed at a higher rate. The doula profession has been around for a very long time. In terms of like its indigenous origins since forever, but as a paid service, it was popularized in the 70s. And so people have been practicing doulas since then, and providing support to their communities and being paid directly by their community members, or providing pro bono services to their community. And so there's already a model that exists for this kind of care. And so if doulas weren't reimbursed at the rate that they are now, then we would not see folks engaging with the benefit, because there's already a model that exists for providing services for free, or low cost, trading, bartering, um, community coming together to support a person who's in need of doula services. And so I think this really came out of a need to help folks to engage with the benefit and see an uptake in folks who are able to access the benefit through Medi-Cal. It's also important to note that doulas don't have facilities that reimburse or that they can bill Medi-Cal for. And so when there's not a facility, then the rate, there's less reimbursement that you can get. So you can't like bill for using the hospital, using hospital equipment, running tests and things like that. And so different than a physician, or people whose primary scope of work is inside of the hospital setting, there's not other things that can be billed for that would increase the overall reimbursement. And so um, it's a misnomer that folks think that doulas get paid more than doctors. That's just not true. Doctors get paid way more than doulas do. Um, it's 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 just that the way that things are billed are much different for folks who don't have facilities. And that includes midwives as well. And that's why we see such a terribly low reimbursement rate for midwives, because they're not able to also include like those facility fees that doctors can when they're billing.
Yeah, true. Oftentimes they can't, based on
Yeah.
their nature of their facility. So thank you for that. It really explains it well. And I also like to say sometimes it's the apples to oranges comparison, not apples to apples. It is really different. A
Yeah.
doula being a client for an hour or more sometimes is different than a 5-minute prenatal visit or a 15-minute prenatal visit.
Absolutely.
There's
And
some
most doulas see their clients for a couple of hours at a time, sometimes up to 3 hours at a time. And so the way that the benefit is carved out is that doulas can have up to 9 appointments with their client, or 9 hours total. But the support that's being provided is just much more comprehensive, like you mentioned, because they're spending so much time with their client at any given appointment.
agree. And I
Yeah.
believe that, the amazing advocacy work that everyone who is involved in this project did to create this reimbursement rate will only help everyone else, because clearly everyone is reimbursed in Medicaid anyways. In maternity care, generally speaking, providers aren't reimbursed what they should be. This will help amplify that. I think this can only do good. Sometimes we think of things as a pie, and some folks are taking from the pie and not giving it to others. But I really feel, and I've seen it already in Midwifery Access California, that the work that the doula collectives did around this will help everyone. Every single provider who knows that they need a higher reimbursement rate really shines a light on paying for value.
Absolutely. I agree. Thank you for lifting up that question as well.
Yeah. All right, everybody. With that, we're going to close out here. Again, this recording will be available to you on the Midwifery Access California YouTube channel as well. So subscribe to that and you'll get all the updates there as well. Midwifery Access CA, that's the YouTube channel. And thanks again, Atisha. Really appreciate it. Have a good rest of your
Thank
day.
you.
Bye.
Bye, everyone.